I wanted to ask the audience, perhaps, just find out a little bit more about yourselves. Who in the room would consider themselves sort of a pure, NTD person? Okay. And how about WASH? Who's really just a WASH engineer, infrastructure kind of person? Which means, are all the rest of you kind of the precious jewel that crosses over the two disciplines? Or so, does anyone feel that they're really working collaboratively across both fields?
Can I add a small
Yeah.
contradiction? Whenever people talk about people in the WASH sector who are uni-focused, they always say WASH engineers. I would like to say lots of people in the WASH sector are uni-focused, and often it's not the engineers, actually. A lot of engineers are extremely broadly educated to solve complex problems, so we just have to be cautious. Social development people can also be very uni-focused, and anthropologists can be uni-focused. So I'd just like to put in a little plea that all engineers are not the same, and all engineers are not the problem, please. Thank you. No, I know it wasn't. I know it wasn't what you mean, but I just wanted to say.
But actually, that kind of prompts me to my first question to all of you. So have you found, over the course of your work, that the collaboration between WASH and NTDs, or WASH and health, has increased? I know, Barbara, you kind of started the day on a very strong note that both the communities have to learn a lot more about each other. Has there been concrete evidence that this is happening now increasingly?
Well, for me, I think it's very interesting because I think it's been on a bit of a cycle. I think there was a lot of connection in the 80s when, the second half of the decade. I think there was a stronger connection. I'm not quite sure what happened in between. I think that connection kind of drifted apart. And I think part of that is that we have a difficult job to encourage people to take action and to do that at scale. We have a little bit of a tendency, I think, and this is a development problem, not an NTD or a WASH problem, to try and find very sort of simple ways of communicating what to do. And so you get a lot of people who sort of enter into the process, and I think this, as I say, this is a problem in development generally, who don't actually come with that kind of like the background grounding, and that's probably a necessary thing. So I feel like there was perhaps a sort of expansion of approaches or skills or trained people who were perhaps not quite so broadly educated across the sort of what I would call the sort of public health spectrum. And I think that's partly why we're seeing this kind of like big effort now with organisations like yours to try and really just reframe that discussion. So I think one of the real challenges for us in looking at the coming decade is probably how do we keep this very rich connection and yet communicate messages and influence public health departments and public health engineering departments all over the world in effective ways. And I don't think we really know the answer to that question. So I do think that's an interesting problem. Not everybody can know everything, but we all know that at least some people in the system need to understand the whole complexity of the problem, because all of everything that you were just talking about, if you're tailoring a behaviour change program, somebody needs to really understand the entire sort of set of social and individual processes. But maybe not everybody does. But how do we manage that sort of from complexity to simplicity? I think it's a really interesting challenge, actually.
Selma, you've been nodding quite a lot in agreement there.
I definitely agree. In Tanzania, we have a Magachi program where we work in 100 health facilities that we provide with sanitation and water. And there we actively sought the cooperation with the health ministries and also with the Infection Prevention Control Alliance that is there. And I think it is, apart from being here and sharing our experience, it is not so much about me or Simavi knowing everything about everything. I think it's also really important to connect the right networks with each other and to effectively exchange this kind of information. Because that is in the end where you can really add different areas of expertise. So we see that in Tanzania it is very much appreciated that we as a WASH organization which is a WASH organization and not a health or an IPC organization, are sitting down with the hospitals, are sitting down with the IPC networks, and really co-designing our interventions and learning from each other.
Yeah.
So I agree, but I also think it is very important to bring together the right expertise and not aim at knowing everything from one organization, because that is not necessarily the most effective solution.
No, I agree. Absolutely.
And do it on the ground. Make sure that in the country you work with, even ministries sometimes in Tanzania, they are not cooperating. Well, that is in essence what should be the basis of improving healthcare systems and WASH.
Yeah.
I agree. I agree with everything being said here. But yeah, especially that part about making sure that it on the ground there's this cooperation. I think that is really important, because if we're all talking about working together but we don't actually go to the effort to find out what's already being done on the ground and what could be built on the ground, then it's reinventing the wheel over and over and over again.
Absolutely.
And the last remark, I think, is that it's also important to not only look at cooperation on knowledge level, but it's also about having finances combined. Because, for example, when you work in health facilities in Tanzania, you have several ministries you work with. You have water departments, you have the health departments. That's the same for the institutional side. It's for how you look at the environment. It's how you look at the technical design of the solutions. So I think it's a much more integrated thing that should be approached from many perspectives, not just one.
James, what were some of
Yeah, I think there's some very good examples. I think one here, for example. But I think if you look overall, it's not happening nearly enough. And I think a lot more collaboration is needed. And even in terms of the NTD community getting together, until the leprosy mission in Bangladesh had a workshop last year, even in Bangladesh the NTD community had never got together. And so, yeah, a lot more work is needed, but I think perhaps if we highlight the good examples, we can encourage people to take this kind of approach.
Alex, do you feel that kind of bringing in your methodology in a completely different way to what perhaps researchers or NGOs have been used to, and sort of accelerate the two working together?
Yeah, I think in terms of communication, helping with communication and really people understanding and appreciating each other and not having competition between each other and working together.
And maybe also one other thing, just thinking back historically, I think we also shouldn't forget that there are very inspirational examples. So, for me, one of the sort of very undersung examples nowadays is guinea worm. But, when I was first working, guinea worm was, that was our big problem in sub-Saharan Africa. And, every single WASH program was struggling with that. And that was a huge, really positive example in lots of countries of a collaboration between, exactly as you're saying, between ministries of health and ministries of public works or water or whatever they happen to be, supported by the international community, with very important signals coming from, for example, from WHO saying, oh yes, actually part of this health intervention is to build your wells correctly, and it is to provide the behaviour change at the household level. So I think there are some really nice stories we shouldn't lose as well, and try and really understand exactly these dimensions that you're describing, to keep pulling out that yes, it can be done, it has been done, and it does reap these tremendous benefits. I think that would be really good. Yeah.
Do you feel that someone with the stature of President Jimmy Carter kind of pushed that along and really worked with the different governments and so forth? And do we need big figures again to take this to the next set of goals?
Well, it always helps, of course. But if we sit and wait for that, we're not sort of helping ourselves. So we have to take our champions where we find them. So if you find them at the district headquarters, then that's where they are. Because that's also where the action has to happen wherever it can happen. So you can have that global side. I'm very optimistic, or I'm a little bit optimistic at the moment, because I think the new Director General of the WHO is in this intellectual space. Maybe not perfectly, maybe not quite how we would want to see him, but he's the first Director General of the WHO who comes from a background where he's thinking all the time about schisto and he's thinking all the time about trachoma. That's his reality. So I think that's a real optimistic thing for me. And I think he's also got a track record of doing exactly what you're describing, or at least trying to make that happen. So to me, he may be one of our big assets, I think. I mean, maybe I'm feeling a bit optimistic today. I was feeling very grumpy this morning, so I'm trying to cheer up.
Adding to that, just one more thing. I think what also has been great examples from our programs is when you have local heroes. We have some local organizations who work with, for example, Maasai leaders who have always been doing OD and also having that integrated in their culture. But once they start seeing and appreciating using toilets, and they do that, and you uplift them and you showcase them as kind of local heroes, that really has a massive impact, not only for the communities that they are leading, but also for other Maasai leaders who might think, wow, that's really cool. I mean, he is like being a hero and all that, so maybe I should do that too. So it's not just about like having Western world heroes, but I also think we should really encourage local leadership and good examples there. That seems to work with our programs.
Anyone in the audience? Oh, yes, lots of comments. Teresa, then Alan.
Teresa Baird at CBN. Just talking about that with your local heroes, do your programs actually actively put people into that position? So within like a community, WASH committee, actually asking women to be part of that committee, or asking some with a disability, leprosy, for example, especially maybe to James as well, that you're actually putting them in that decision-making process with everybody else, and then it's even easier then for them to be seen as that local hero that will then start with the empathy, the understanding their situation, because it's being discussed at the same time as they're deciding where the water supply will be, or what design the area will be. Do you do that?
Yeah, all of our programs start with getting into a oh yeah.
Would you mind to try and use the microphone, because I'm just worried. I'm not sure how much you can hear us that loud.
When they don't all have an arm.
Yeah. There's some handheld mics down here.
We're supposed to. I feel like I should juggle with them.
Yeah, there they were. Apologies for the lack of microphones for this first session.
Okay, I'll give you one, and we'll try and apply our brilliant brains to see if we can make it work.
Yeah, I think it's the microphone.
Or the red one. Just talk among yourselves.
Yes.
It's fine.
That's right.
Maybe it works. Just hello. Is there a general visual? No, it's not.
I will try to use this. What I wanted to say, is this better? No.
No, this is just me.
Yeah? We always start to have a discussion with the beneficiaries, so to say. I think they are more like participants in a program. That's for schools. We really sit down with headmasters and with the teachers themselves. For the health facilities the same, for the communities the same. And we have a very social inclusive approach. So indeed we try to emphasize the involvement of women. We really stimulate them to include people with disabilities and people who are at risk of being left behind. But from there, we are not putting people in a hero position ourselves. It's not that we from Simavi say, you should be a hero, and you should do this and that, and you should be in the paper, and you should be... That's not how it works. But we really try to stimulate people to get enthusiastic about certain behavior, and then uplift them from there to create an influence on their own communities. So it's really a facilitating role, more from a discussion with the local leaders and all people who should be involved, and that we create kind of like leaders in now we'd like to do it more in a natural way than deciding upon that for ourselves, because that doesn't work. You cannot put like a sticker on somebody that says, now you are the local hero and you're going to do this. It has to really come from what was mentioned in the Acting for Change story. It has to come from someone who understands the need for change and who's enthusiastic about it, who identifies with that, because only then you can actually get people with you to change your behavior in a healthy way. So that's basically how we try to approach that.
Yeah, I think, yeah, we try to get inclusion all the way along. So in KKM, our partner in Sri Lanka, even on the board of the organisation, there's people affected by leprosy. And then when we're on the planning committees, there will be people affected by leprosy. How we use champions really is more to do with advocacy and raising people up who can speak for the rights of people affected by leprosy. And that does include WASH. I'm thinking I was recently in the north of Bangladesh, and there we work with self-help groups, and these groups have been worked with for a number of years, as well as getting some microcredit support and things. They've also been empowered. So actually, as groups, they've been able to go to the local councils, the local Union Parishad, and say we need latrines, and the local government has provided them. They've gone and asked for water sources, and they've managed to get them provided. So that's kind of the angle we take.
Alan.
Thank you, Alan Imperial College. I'm moved by this just to take a couple of minutes to think, how on earth have we got to where we are today? In the 1960s, as Barbara mentioned, there was collaboration, and there's an awful lot of papers published on particularly schistosomiasis in the 60s, where individual researchers had a little pot of money and they worked in one small village here and one small village there, and then recommended, yes, we should treat everybody and give them water and sanitation. And then in the 1980s and 90s, there was virtually no money at all, and the net result is there's actually a void of parasitologists who just didn't have any money to work in that time. And then in the year 2000, with Bill Gates coming on board, and he supported a number of us to actually do implementation with available drugs, and then there was the push forward of the drugs being donated. We had to use those drugs while they were being donated, otherwise they would be wasted, and that was where WASH, to my mind, got a little bit left behind. But now, we've got as far as we can go with the donated drugs. And if we're going to go the push to elimination, that's when we want to bring the water and sanitation people on board. For the last 10 years, we've had meetings of NTD people, and we've had one token WASH person there. Now, we need to go much further. And it's fantastic where we are today. The ISNTD, for example, we wouldn't have dreamt that that could have existed 10 years ago. So I think what we've got to talk about today is how we can just get that integration. There's loads of WASH stuff going on, and there's loads of NTD stuff going on, but how much talking is there between the two groups?
We'll take one more question before we break up the call and continue our journey.
Hi, I'm Eve from UCL. Kind of following on from that point, and something that Barbara mentioned as well in her talk, was about the RCT trials. And we've just done a review at UCL looking at health impacts and WASH. And kind of one of the big findings really is that there's very few RCTs. But is that necessarily a bad thing in terms of pushing forward the WASH and trying to contribute to health outcomes? Because, but also does it prevent kind of health people listening to the WASH interventions, because we're not doing, or WASH engineers possibly aren't doing these studies in a very kind of at the top of the hierarchy of research methods. So I was just wondering what those studies were that were also giving negative impacts, and that, and what, how do you,
I think it's a really interesting question. So in the last 8 years, we've had 5 really, really significant major RCTs, big multi-centre RCTs, specifically looking for health benefits as a result of sanitation interventions. And the results are very mixed. And that came about, was actually very significantly driven by Bill Gates, by the foundation, kind of pushing for evidence-based policy making. And I think we really missed a very serious trick in the WASH sector, because the thing about an RCT is, because it's a methodology that comes out of the health sector, then we nearly always use health impact as the effect that we're measuring. And one of the things we don't measure very well is the outcome, which is what you want, which is less shit in the environment, or even one step back from that, everybody using the toilet when they need to use the toilet. So a lot of those studies are faulty because the whole sort of theory of change is not included. They've been designed, some of them, a bit as if they would be drug trials, where the link between the intervention and the impact is very direct. Whereas, as all of you know, and Alan knows, and it's a complex web of connectivity. So if you don't look at what's happening along all of those lines and webs, you can't work out why you do or don't get the impact. I think we're at a slightly hazardous moment, and the reason why we do need to think about this, and I would really appreciate a conversation about it, is because, just to give you an example, in the WHO, in the update to the Sanitation and Disease Handbook, which now has a new name, and in the Global Burden of Disease calculations, which are always made, the estimate of the effectiveness of sanitation, hygiene, water, combined sanitation, hygiene and water interventions, and then those combined with drug interventions, is being significantly underestimated, not because there isn't an effect, but because we don't have very much proof. And I think we're going to have to make a strategic decision. I mean, I think the RCT problem is really difficult, because doing a really, really good RCT in this area is very tricky, because implementing totally effective WASH programs is really tricky and very long term. And the RCTs are generally not long enough. So the SHINE trial, which is the one that's just reported, was probably designed and implemented by some of the very best public health people in the world, and certainly some of the world's best parasitologists, and a whole bunch of really smart people. But I don't think their WASH intervention was great, to be really honest. So I think it's a conversation we need to have: is should we be pushing for more observational trials? Should we be looking at more cohort research? And I really think we have to make a big push to get more people to be monitoring the right outcomes in projects and in research. And for me, that's the big gap. We know a reasonable amount about outputs. People don't mean to do it, but you end up, talking about, I had this many meetings, or I formed this many groups, or I had this many local leaders, or whatever. And that governments like those numbers because they're quick and easy to report. And then we've got the sort of health people who are looking for something which actually is a more complex long-term impact. And I think the gap is in really getting smart about measuring outcomes. And if we got smarter at that, we could then make much more convincing cases, I think, at the outcome to impact level. So I think it's a huge gap. I think there's masses of work to do. We've got to do it smart, and we probably won't get quite as much money ever again. I think Bill has probably had his time throwing enormous money at us for RCTs, so we're going to have to do it smarter. But I think it's a really interesting question, and I'd love to talk to you about it more.
Right, thank you. I think it's time to take a little break now. If you want to read a bit more about our speakers, please do pick up a copy of the conference handbook, which is around the coffee area. And obviously, we've been shortchanged a little bit of your coffee time, so we'll extend that in 10 minutes past the normal time. And also, I just wanted to apologise for my team for the issues with the microphones, and we'll resolve that while you all enjoy a little tea break. So, see you back here at 11:20 or 25. Thank you.